Welcome everyone to today's webinar, Avoiding the Hidden Wave of Costly Chronic Disease Hospitalizations Post-Pandemic, sponsored by CareSignal. I'm Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link used to log into today's webinar to access the recording. At this time, it's my pleasure to introduce today's presenters. Blake Margraf is the CEO of CareSignal. Blake leads CareSignal in developing evidence-based healthcare technology to deliver clinical and financial returns for patients and healthcare organizations. CareSignal, founded in 2015, serves dozens of large health systems and payers across the U.S. Dr. Carla Beckerle is the Vice President of Clinical Programs at Esse Health. Carla has over 40 years of experience in a variety of healthcare settings. In her current role, she oversees strategic planning and implementation of the company's home health, skilled nursing, hospital case managers, dietitians, and wellness teams. Erin Stam is the COO of Esse Health and oversees the organization's population health and value-based care models. Prior to joining Esse Health, Erin served as the Administrator of Health Information Management at Washington University School of Medicine's Department of Orthopedics. Dr. Chris Schlanger currently leads Digital and Population Health Strategy at Mercy Virtual. His work encompasses needs identification, business case planning, and execution of the clinical and technical aspects of creating a full digitally enabled care continuum. Dr. Schlanger also practices as a board-certified emergency medicine physician. Rob Jeanettin is the Director of Innovation Partnerships at OSF Healthcare Systems. He has 20 years of experience in the healthcare industry with an extensive background in performance improvement, change management, simulation, and usability studies. As the Director of Innovation Partnerships, Rob is focused on building strong commercial partnerships that will impact costs and clinical outcomes, as well as patient and employee experience. At this time, I'm pleased to turn the floor over to Blake to begin the presentation.
Awesome. Thank you so much, Mackenzie. It's a privilege to join everyone today, and I'm grateful for everyone for taking the time to join and for these speakers for taking the time. They represent truly some of the best and brightest healthcare executives across the country. Excited to share their perspectives. Let me provide a brief overview of what we will be discussing today. I intend for this to be a distinctly evidence-based webinar, and anyone who's bumped into CareSignal in the past knows that that's really our mantra, so really nice to bring it to the webinar format. Over about 85 different peer-reviewed journal publications, most of which were focused on the SARS epidemic in the early aughts, I have tried to extract a range of learnings that apply to clinical, operational, and financial implications of the COVID-19 webinar. And the best outcome of that part one of this presentation is that everyone hopefully is able to take away a couple of actionable insights. And that should really lead us to parts 2 through 4. I'll provide a quick overview as to really CareSignal's approach in all of this, and I do mean quick. We'll keep that very brief, highlighting some of the philosophy behind our technology approach. And then we'll dive into the meat of today's discussion, focusing on the approaches of Mercy, Esse, and OSF Healthcare. And I've chosen to highlight a few of the respective strongest suits of these leading organizations, everything from how to effectively and scalably bring virtual care to patient populations, especially while all of us are essentially experiencing life as rural patients during lockdown. Esse, which is, by really any measure, one of the most successful Medicare Advantage players in the market today, and how they do that not just by bringing care, but also by emphasizing relationships with their populations. And OSF Healthcare, and I wouldn't be surprised if just about everyone on the call has heard OSF mentioned in the same breath, as innovation or venture funding. Really, they punch far, far above their weight class along the likes of Intermountain and Cedars-Sinai by emphasizing the innovative approach. And then, time permitting, I'll share a few additional observations around challenges and opportunities when it comes to enacting many of the learnings today, but really we'll make sure we have plenty of time for questions. With that, let me go ahead and kick it off. The two studies I've chosen to emphasize when it comes to historical precedent for the SARS epidemic really apply a couple of simple learnings, the core theme of which is during COVID-19 style situations, patients, and especially the most vulnerable patient populations, such as those with ambulatory sensitive conditions, perceive their care to be less necessary. And that applies truly from gastroenteritis to tonsillitis to lower limb fractures. While the incidence of flare-ups doesn't decrease, utilization does. And studies of more than 260 diseases broken into 25 categories provide a pretty comprehensive view of this impact. Unfortunately, those diseases also don't get better. Mortality as a result of diabetes mellitus, cerebrovascular diseases increased significantly during the 2003 SARS epidemic. By more than 8% and 6% respectively. And lots of analysis shows that this was almost certainly a result of the loss of control of conditions associated with the necessary remote time spent. I think it's worth noting that even conditions such as anxiety, which in the mid to late aughts when this synthesis was being conducted, also showed reduced utilization. So really all of the things that we now know are major drivers of cost and increased morbidity among patient populations, almost regardless of comorbidities, worsened during the epidemic. I'd like to move now to utilization trends specifically around chronic ambulatory care sensitive conditions, and a bit of context as to why I've chosen to emphasize ACSCS as opposed to chronic conditions in general. The Agency of Healthcare Research and Quality, I think, has done a really good job of using ACSCS as markers of both access and quality. And when it comes to applying learnings from history to our situation today, ACSCs are perhaps the most effective way to do that in an apples-to-apples manner. So American Journal of Public Health notes the reductions in utilization, and those 23% and 35% reductions respectively are really nothing compared to what we're seeing, as we'll see in the next slide, not to get ahead of myself, but COVID-19 has resulted in more than double that reduction in utilization, which is pretty scary. Also surveying more than 120,000, I think it was 120.3 thousand hospitals in a population-based interrupted time series study, which was selected as the most robust way to look at admission rates. The admission rates for a lot of those conditions didn't bounce back in a way that was financially productive to organizations. And despite the healthcare incentive differences, which we won't explore too much in Taiwan and other impacted nations as opposed to the United States, it's worth all of us knowing that we can't plan on essentially seeing a resurgence into patient volume in the near future at all. And unfortunately, more bad news on that front. A long-term study published finally in 2008 showed that in the years following, volume only returned to 82% and then 84%, where it was almost halved in the year of SARS itself. This was striking to me because in most conversations with industry players, the assumption seems to be that the impact should wane relatively quickly, and obviously that's not the case, especially given the more widespread nature of COVID-19. And finally, looking at very recent research by the National Bureau of Economic Research, as I mentioned, we're seeing a 67 or greater % decline in utilization just in the beginning of April, which shows us really, if anything, that we can take these outcomes that were seen during SARS and take them as evidence that this is happening again. Hopefully now a bit of a silver lining. new economic research and even thought leadership suggests that given the prevalence of digital technology and telehealth, and really the ability to form and maintain a productive clinical relationship with patient populations during our current pandemic, there may be a way for the same providers that could be in dire financial straits, not only this year, but for the coming 2 years based on past research. There may be a way for those organizations to capitalize on everything from market share increase to improved relationships with patients that represent the path to financial success. And I'd like to view that in the context of kind of a three-part summary of the past research. So first, we have to lean into the reality that patients that are frankly most likely to experience adverse outcomes if infected with COVID-19 are also the ones who are going to use fewest healthcare services. And the fact that they use fewer healthcare services will negatively impact the chronic conditions for which many organizations are financially responsible. Unfortunately, there's not really a bounce back either from revenue or clinical outcomes there. So providers that take a wait and see mindset as opposed to moving aggressively during this volatile period have the most to lose. And then, of course, the silver lining, which is by driving new avenues of digital engagement, and that doesn't necessarily need to be a dramatic investment or even a serious operational undertaking, but by leaning into that, providers and many other types of healthcare organizations as well stand to win on all fronts, operationally in terms of relationship, but crucially in terms of clinical outcomes and of course, revenues and financial viability. And that fiscal medical balance, I think, is pretty encouraging. That's specifically relevant for the ambulatory care sensitive condition populations, at least based on research so far. So I'll take just a couple of minutes now to share the philosophy of CareSignal, just a few slides for a moment, and then we'll move to start with Mercy, then Esse and OSF, to see how the healthcare executives and leadership behind these rapid response strategies are driving outcomes of their own. CareSignal's philosophy, as you can tell by the start of our discussion here, is evidence first always. It's really just as simple as that. I'm proud that our company now has 10 peer-reviewed journal publications, with many more in the pipeline, showing not only the relationship and operational, but also clinical and financial outcomes for some of the most challenging patient and member populations across the country with representative randomized controlled trials. And this is a means to an end, right? This is a means to not only a better product, but also a more productive relationship with industry partners. Because only when we can build our ROI model bottom up, knowing the percent of a population that will engage, knowing the percent that will reduce readmissions, only then can we really have a conversation about how this is, again, financially viable and thus clinically impactful. No mission, no margin. The opportunity from a theory perspective here is to take patient-generated data, and I'll share our technology on the next slide, but take a population that's well known to be high risk, especially during this really challenging time, everything from heart failure to COPD to behavioral health conditions, and to separate that population into 99% of patients who are okay on a given day, and then the 1% that need intervention, and not just intervention, but clinically informed intervention in order to maintain their own trajectory. And CareSignal uses really the most ubiquitous technology to do that. We use text messages and phone calls, all completely white labeled, so coming on behalf of our partners. We even take it a step further and make sure that from an operational perspective, we cover all of the engagement and enrollment. And because of our condition-specific approach, with more than 24 condition-specific programs, we're able to align strategically, and that's proven to be really important, I would say completely necessary during the COVID-19 pandemic. The other benefit here is long-term engagement. We have industry-leading engagement, anywhere from 6 to 12 times better than the next comparable programs in terms of remote patient engagement monitoring, because of our focus on accessible technology, evidence-based content, and then clinically actionable insights delivered back. But that's enough of that. So now I'm very excited to introduce again Dr. Schlanger on digital health, overseeing all digital from Mercy Virtual. And Chris, if it's okay, I'm too used to calling you Chris, so I need to stick with it. Let's start off. What's been most surprising going through the COVID-19 process in the context of Mercy Virtual?
Sure. Thanks, Blake. Perhaps the most interesting and noteworthy aspect of what we've learned is that, as trite as it may sound, relationships really do matter. It's not about the technology. And in fact, every bit of sophistication that we add to the process is a friction point, and it's an opportunity for patients to drop off, not only to not engage or to disengage, depends on the circumstance. We've found that simply maintaining a patient relationship and a warm connection in whatever way we can do that has delivered the most results out of any of our clinical or performance metrics. And with that, we've recognized that as we've started and as we've built a lot of our early successes on some of the more complex and substantial care management, as we want to expand into a much broader population and have more of an impact across more patients, we've recognized that we just can't throw bodies at that problem. We have to do something more scalable, and we have to also not overload our patients with care that they don't need and attention that isn't providing them any benefits. As we've experimented this, we found that in a lot of ways simpler really truly is better.
That's I think a point worth exploring. So simpler is better, and of course simple is relative to the patient disease burden and tech capability. How do you balance that type of stratification? And if you're game to even share specific examples, you have some of the most robust patient monitoring technology in the world. You also have some of the, I think, most accessible and lightweight digital front door solutions as well. How do you go about striking that balance?
Sure. I think in a lot of ways we started with the approach that many have taken, which is to recognize the disease burden, or essentially how sick is the patient, and then tailor our attention accordingly. And some patients that have a pretty substantial burden are very sick. They've got a lot of chronic diseases, many of which interact with each other. Those are the ones that we recognize are just going to require a lot of attention and a lot of ongoing side-by-side support, whether physically or virtually. But for other patients, sometimes the best way to know how they're doing is just to ask them. And they don't necessarily need devices to do this. I mean, there's always going to be that subset that will. But in these other broader populations, we've recognized that the ability to just simply communicate to a large number of patients is probably far more effective use of our resources than taking the, same amount of attention and resources and concentrating them on a much smaller group. In this broader population, we realize that we can't always know which ones will develop escalating care needs in advance. So we have to have kind of cast a wide net and have a really far-reaching radar. And in those patients, almost by definition, they're not that sick, at least at the point that we're establishing these plans. So they don't need the intensive upfront support. We can escalate them when and if that's necessary. But for now, or at least to start, we just want to keep the lines of communication open.
That makes a lot of sense. And, as a closing point, given that COVID-19 truly is acting as a crucible for all players in the healthcare space, what do you view as perhaps, I wish it hadn't happened this way, but some of the opportunities that are coming down the pipe, both clinically and financially?
It's a good question. We've recognized that sometimes things are the way they are for a reason, and those reasons don't necessarily have to make sense or at least be in the interest of everybody. And as some of the unnecessary or no longer useful barriers, regulatory and perhaps awareness have fallen, both providers and patients have really jumped on the care bandwagon. There are a number of stereotypes, fuddy-duddy doctors, patient populations that would just be overwhelmed with technology. And yeah, there's probably some heterogeneity in both those populations, but the patients are ready and have been waiting, and the providers have been more than interested in doing this, but they've just had their hands tied behind their backs. So as we find every opportunity to either knock down some of the big barriers or at least chip away at some of the smaller ones, again, removing the friction and simplifying the process, we found that adoption and uptake of the virtual services is just skyrocketing.
We're seeing the exact same. Thank you so much, Chris. And to everyone listening, I mean, you'll see, please don't forget to toss any questions into the Q&A section so that Dr. Schlanger can provide direct feedback to those at the end. I'll make sure there's plenty of time. Moving to Esse, and every time I'm describing Esse, it's for the few folks in the industry that are not yet familiar with the outcomes that Esse has managed to drive. I think many people don't believe me when I describe the positive clinical and financial impact that Esse has been able to affect. And Aaron and Carla, as the two masterminds behind this, both from a technology and operations perspective, but then really the rubber meeting the road on the clinical programming side. Let me start with the same question as with Mercy. What's been most surprising to you over the past, hard to believe, 2 months?
This is Carla, and Dr. Schlanger, you made a lot of great points in your discussion points just now. I think that what has been surprising to me is that those individuals, and you talked about the fuddy-duddy physicians, that I never thought would touch a virtual platform have done so, and with success and with a lot of enthusiasm. And I think that we have been moving very slowly in this virtual footprint that Aaron and I just keep wanting to push the pedal to the metal, but we've had a slower response until now. And I have to brag on the IT department of our company. We had everybody ready to go in a virtual methodology in like 2 days, and talk about making your head spin. So it was definitely a impetus to move forward and to use the technology as it really can be used in a really positive way. We have a large Medicare Advantage population, and Dr. Schlanger also said that, that there is a stereotype that people that are over 65 don't know how to use technology, which is totally untrue. And so we have 4 disease states that we've been involved with using Care Signal technology and the app that we have. And it's been heart failure, hypertension, COPD, and diabetes. Now, those are 4 chronic conditions that frequently need more frequent touches than we have historically provided. But because we've been doing this for many years, we know how important it is to address issues for people so that we can assess the need for any kind of preventative services they might need or any kind of secondary services. So that's been our mantra for many years. And my joy has been that our population has really enthusiastically embraced it, and we have seen great secondary outcomes with these disease states. And we have a lot of happy patients. They really, really do feel like their care team does care about them, and they feel like their care team understands and knows what's going on, because we do. We have a closed feedback loop so that our care manager that is involved with the 1,500 patients that we're currently taken care of in this program has immediate access to not only the physicians but the offices. So that's really an important piece. The care that happens needs to be team-based, and we've been able to do that on Octane with our COVID experience. And with that, I pass it to Erin.
Yeah, thanks, Carla. I just echo your comments completely about the biggest surprise has been how quickly the organization adapted to, technologies that we were just sort of had our toe in the water with, but it was certainly, as my team likes to refer to it, it was certainly our Amazon moment and busting through barriers to how we have provided care virtually in the past. And I would say with a couple of things to add just from an operational and technical perspective, when we use CareSignal is when we're looking at options, we needed to make sure that, yes, we have some folks who can use text messaging without any issue, but also that phone call that the system has the capability to do has really made an impact on the response rate for those patients. We have a large cohort of patients in our Medicare Advantage platform that's above 80, and they seem to be our ones who certainly prefer having that house phone in their hand to be able to respond to questions. And interestingly enough, the other surprise that's come up with this is we're constantly looking at access and the patients who are frequent flyers to the ER that aren't appropriate to be in the ER for whatever their complaint is or presenting problems. How do we get those patients to, call their primary care physician first so we can get their issue addressed before it comes to, I need to go to the ED for a visit. And we've done studies on, if we expand our access at our location, does that help patients, refrain from going to the ED when we can help them in the office and it doesn't need to be treated there. And there is absolutely correlation between obviously having access extended at your offices. But in some of the patient interviews, time and time again, and Carla can comment on this, it's that, I don't want to call and bother my doctor. I'm bothering, him or her with my issue. And I think with this, the tables have sort of turned in a way that now my doctor is calling and checking on me, and they don't feel like they are bothering us anymore. We're getting that care to them before it becomes a much larger issue that needs to be addressed. So those have definitely been some of the positive outcomes that have come through this. And from a technology perspective, I'm always worried about what is something going to do to our already overburdened tech stack with everything that's going on in that side of healthcare. And this certainly was low impact to that. So that was much appreciated. And I think certainly helped us roll things out quickly and get it in the hands of our patients in a very timely manner.
Really, truly grateful for that. Another area, Erin, where I think Esse, the industry can't really know what's going on behind the scenes, and thus Esse doesn't necessarily get the credit that it definitely deserves, is, you are extremely at risk. And now a lot of organizations across the country are thinking, man, I wonder if I'd be perhaps better off if I had maybe some more of that going on for myself. But that doesn't happen naturally. And when the pool of dollars that are truly yours to spend is extremely finite, it means all the more need for focus on not just a return on investment, but focusing on a time horizon that's reasonable. Any thoughts? And honestly, just procedurally, as you're looking at technology, but also just internal decisions, how to choose the best direction, and knowing when to double, triple down on that direction as a means to a financial end.
Yeah, and we use several tools at Esse. We look at our claims data to really analyze what's going on, and then partner with Carla's team on where we need to focus our care management resources, because again, those are finite. Also, we would love to have double, triple the amount of folks in Carla's team, but the economics have to be there to support that. So really through all of that claims analysis, you're absolutely right. It's the horizon on how we have to spend some money up front for an outcome that we, desire to happen, but, there's a time period that has to make sense to do it within, because they're absolutely at risk for those dollars. So that's how we've partnered with care management. It's all about data and having that data real time to see what's really going on, like you said, behind the curtain in claims. And then we've put all the patients that we've enrolled in Care Signal in cohorts in another platform that we utilize, so we can track them specifically and we can manage them, as well as look at that data over time to see how that group has done both clinically and financially during this or with this platform. Carla, did you have anything to add?
Well, yes, I do. And yes, thank you, Erin. My comment is that I have the luxury of being in an organization that cares about the triple aim. So whether we're doing an ROI on whatever kind of initiative we're looking at, or whether we're looking at an issue around patient access or any kind of issue, we are looking at all the prongs of the stool. We're not just looking at, it's going to cost us, $10 to do this. We're looking at what are the outcomes going to be. We're using the evidence to make the decisions, and then we're looking at how it's going to impact our patients. Because if we're taking care of our patients, not just in the risk contracts, in all of our contracts, and we're doing the right thing, then the results will happen. And that's a situation that a lot of folks really don't experience in their professional life, and I'm grateful for that.
It's a great point, and fortunately, I think we'll have the opportunity during Q&A to dive deeper in a couple of areas there. So with that, let's transition to OSF to get a third perspective. And this perspective, I would say, is multifaceted, but the common thread is, OSF healthcare is focused on innovating, but validating. It's almost the healthcare system version of trust but verify. And a few areas that at least in my own view, make OSF really unique to comparable health systems is their focus on centralizing the innovation model, and of course, finding evidence prior to doubling down and scaling, but then not losing sight of what's at stake in terms of supporting both providers and community. Really, Carla, to your point on the triple aim. With that, pleased to reintroduce Rob, the Director of Innovation Partnerships. Rob, please to start wherever you like. I'd definitely be curious to hear, about some of the most surprising moments over the past couple of months and stories that have happened, but also your own philosophy when it comes to driving very rapid innovation in an otherwise slow-moving industry.
Yeah, thank you. Like a lot of health systems, this has been, quite the challenge and quite the opportunity, especially over the last several months. And one of the things that's been made very clear to us is how thankful we are that we got started on a lot of work very early on. And so we really kind of centralized our innovation efforts about 5 years ago under one kind of brand, so to speak, of OSF innovation, and brought together some of our data analytics group, our simulation and education group, brought all of our performance improvement resources together, stood up our Office of Innovation Management to start leveraging internal ideas, and then also my group, which is external innovation, and looking at how might we partner with the larger innovation ecosystem. And through that, we've had a lot of relationships built, a lot of work started, a lot of work that has made its way into full flight. And through a lot of the digital work was a recognition that, boy, we really needed someplace for this stuff to live. And someone to really take it and operationalize it and be strategic with it. And so I think about a year ago, we stood up our OSF St. Gabriel Digital Health Group and brought in a hospital president to run that and backfilled her previous position and really put some resources around what is the digital approach that we're going to have and we're going to take, and who's going to be able to provide the resources, the competencies, as well as as well as the man hours and the labor in order to be able to pull all that off. And thankfully, quite thankfully, we had all of that in place, albeit quite new on the St. Gabriel side when COVID came around. So what that group really did was start to take some of their 5-year, like a lot of places, you take your 5-year plans and start to do it in 5 weeks or, 5 days maybe. But, those types of things and being able to kind of look across the entire continuum of digital and tele and all of those, and from some of the very heavy-handed things that Dr. Schlanger was talking about, all the way across the continuum to some very lightweight, scalable, and highly impactful efforts, and Care Signal certainly falls into that group. So, we've been focused on this for some time. We think that the need for this is only going to increase, and that was pre-COVID. But I think this has just really shone a light on the opportunities that are there for access, for clinical outcomes, for ROI, and for both patient and provider satisfaction around really tech enabling some of the care that our mission says that we will provide, regardless of circumstance.
Which is pretty inspiring. In terms of what's next for St. Gabriel, Rob, what has you most excited, and how do you view that as a means to even further accelerate finding new innovations and bringing those to bear?
Yeah, I think St. Gabriel is it's a very exciting part of the organization. They have a very talented leadership group. They have a very talented group of folks supporting that, and I think it's going to be exciting to see where they take it and how exactly that's going to spread and really be impact the communities that we serve and perhaps beyond that. For me, on the innovation side, I really, it's wonderful to have a place. We talk about wanting to be, evidence first and being able to show some of and validate not only the solution and the vendor, but also our internal workflows and our skill and will to be able to support these types of things, and all the while having a plan to scale. And so it's really great with St. Gabriel to be having a place that we're pretty sure these tools will end up in the event that we decide that that's something that we really want to take across our ministry. So we do take that approach. We try very hard not to just pilot to death or pilot for the sake of piloting or think small. Everything that we do is with a plan to scale. And so, in fact, we're trying to get away from using the word pilot. I think we're just kind of phasing our implementations would be a better way to say that, I think.
Yep. No, that's another area where, at least in my opinion, OSF is leading the charge. It's productive, again, financially and clinically. So thank you so much. Please continue submitting questions. Great questions coming up, everything from the approach to ROI analysis to impact on certain conditions, and where possible, my colleagues and I might even be able to supplement by sharing out case studies after the fact to make sure that we cover as much ground as possible. I'm going to move here through the final 3 slides, which are designed to summarize some of our learnings from the 3 phenomenal partners on the call today, and also from our other dozens of industry partners over the past weeks and years prior. First, and this has certainly been a theme, is technology only works if the rubber meets the road, and then if it's scalable. And you know, looking back, if there's one thing I wish I could tell myself 4 or 5 years ago, it would be to focus on that. You know, the outcomes, of course, are vital, but it's the old adage: if you have a pill that cures everything and no one takes it, then of course it has no impact. Just a few outcomes to highlight there. You know, with CareSignal, we usually see care management teams that are frankly overstaffed. And that's not a criticism. I think it's a necessary reality to accomplish the mission that a lot of our partners have. But usually 30 to maybe 100 patients, and these are, I grant you, very high acuity, you know, high risk patients, the exact same that we've analyzed at the beginning of this webinar. And we consistently see scaling that ratio up about tenfold, you know, 10 to 15-fold to 1 to 300 to 1 to 1,500. That 1,500 number actually being for heart failure, diabetes, hypertension, really, you know, high morbidity population. The next combination challenge and opportunity is making sure that when new technologies are introduced, they augment relationships and they don't replace relationships. I think attempting to cut out the deep, often emotional relationship that populations have with their providers is a recipe for disengagement, which of course means wasted money, and that's no good for anyone. A few of the explicit pieces of patient feedback, different quotes that we have on the slide here. So that's certainly a big focus for CareSignal. And the final learning ties to Dr. Schlanger's points in particular, where organizations often have the ability to retrospectively stratify a population, and I think guided by history here, we see that that's more important now than ever, and then of course to intervene in a timely way, and CareSignal fits between those 2 phases of the approach. Although it comes back to, if you've seen one health system, you've seen one health system. There is absolutely not a one-size-fits-all approach here, and anyone who says there is, I think, hasn't undergone implementations with you know, a diverse set of payers and providers. That's a big focus as well, as, you know, engagement only works and thus leads to outcomes and financial returns as long as there's a strong solution stack. We're just a couple minutes before the 45-minute mark now, but I am really keen on getting to many of these questions, especially I'm so grateful for the time and energy of our healthcare executive presenters. Mackenzie, if you're up for it, could you please take the ball and toss the questions over to the presenters?
Yeah, that sounds great. Thank you so much, Blake, and thank you all for such a great presentation. We'll now go ahead and start today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. And we've got about 15 minutes here, so we'll try to get through as many questions as we have time for. The first question we have here is for the folks at Esse. This audience member is asking if you can talk more about your ROI analysis process.
Sure. So this is Erin. So when we decided to start using CareSignal, we have probably 15 years worth of claims data. So the patients that we selected to go into this program based on some criteria that we worked with Carla's team over, who was rising risk, et cetera, would be appropriate. We put those patients in a cohort, if you will, and we looked at historic trend of ER utilization and their spend, and then tracked them through now being on this platform and how many visits that they had going forward post-care signal, what the spend was, what the ER visits were, and then we also compared that to the average per the other group that was not enrolled in care signal. And so we did an analysis on what our spend was for that group of patients pre and post, and then that group of patients normalizing that to the group who was not enrolled in care signal.
The other thing that we looked at were the outcome measures. So for hypertension, we reduced both diastolic and systolic blood pressure utilizing the technology. For diabetes, A1C was reduced by actually almost 0.5%, which is amazing. And for heart failure and for COPD, we used the ED visits and the admission criteria reduction because that's a standard that's used in a lot of environments. So we really were able to have measurable positive outcomes, and people get sick here at Esse Health of having me say this, but it is all about self-management, because what our patients did was do the work of using the app, thinking about their health, and then reaching out if they had any kind of questions, and that's when we would get the alert, and then we would intervene at that time. But it's really, really important to know that, that we are not the heroes, they are.
Absolutely. Thank you both for weighing in on that question. We've got another one here from an audience member who is asking, is this technology integrated in the EMR, and what EMR do you have? And maybe we could have folks from Esse and Mercy reflect on this one.
Sure. So this is Erin with Esse, and we utilize NextGen, and we utilize NextGen at Esse. We do not have a direct interface with CareSignal. It can live outside of the EMR, which was great for a ramp-up time. We didn't have to go through all of those hoops. We could just begin using it standalone, but then the documentation and everything that occurs with the patient obviously is all contained with one EMR, but we do not have an interface between the two platforms.
Yeah, this is Chris Schlanger at Mercy. Similarly, we have a somewhat centralized care model where we have providers that can respond essentially 24 hours a day to these things, so they don't end up in an inbox that may or may not get managed as quickly as we want. And as such, all of the information eventually does make it to the Epic record, but the live responses are handled initially in a separate platform.
Yeah, and
this is.
Go ahead.
Go ahead. This is Rob with OSF. We are an Epic shop, and we do have CareSignal integrated with our EMR. Not unlike Mercy, we do use the Epic dashboards definitely to look at things real time. All of the information is available in Epic, and we're also able to order various CareSignal modules through our Epic integration.
Perfect. Thank you all for the clarification there. I think that's really helpful for audience members to hear. The next question is about clinical outcomes, and specifically if you all are seeing a reduction in readmission due to the new model.
This is Chris at Mercy. Anecdotally, I can say yes. However, the math around which we would say that gets surprisingly and unexpectedly fuzzy. We are currently deploying this in both an ongoing chronic care configuration as well as a targeted and a little bit looser entry criteria for a 30-day program. So basically, almost any patient that would even remotely qualify as a hospital discharge would be enrolled in this. We're seeing some initially very encouraging results, but we haven't collected the data in publication format yet.
And this is Carla Beckerly. We have done the analysis with the care signal data, which I've alluded to. And yes, we have seen reductions with the admissions and the ED visits for both heart failure and COPD. And we're very focused on timely intervention, as many of us are. And so this was really important that we did that evaluation and reported it through our channels so our physicians understood that this tool was not only valid but very helpful in care.
Perfect. Thank you again for the insights there. Looks like there's been a few questions coming through about the staffing ratio. So maybe, Blake, you could weigh in on that a little bit and provide more clarification for our audience members, if you don't mind.
Absolutely, glad to do that. Let me hop back to this slide, which is very high level, so I'd be glad to follow up with more information as well. The staffing ratio, so first to level set, there is, without any question, a need across all of our current partners to improve staff scalability, especially while the financial pressures increase, just unfortunately during COVID-19. While our goal is not to replace staff for the sake of replacing, it certainly is a way to make sure that individuals operate at the top of their licenses. The staffing model that we use most of the time that's led to this ratio is a centralized hub and spoke model, and really all three organizations can speak to this in their own forms, but as a high-level summary, this generally means having a virtual care coordinator or a virtual medical assistant, different terms used, as the center of that hub and spoke. That person could really be a medical assistant, no formal license required. And then as alerts occur, generated by Care Signal for the thousands of patients with different high-risk chronic conditions, that individual is able to determine the appropriate course of action. Mercy is a great example of a leader in this space, having created their pod system to enable one physician and a series of NPs, but then a broad number of lower licensed individuals to successfully manage quite a lot of patients at scale. So to the rest of the team, any additional thoughts or detail on that staffing side?
This is Carla Beckerly again, and my additional comments would be that we're using the same model with a hub and spoke kind of mentality, but for our company, that individual who is an MA communicates with that patient and then connects that patient with the appropriate personnel. And because we're a team-based model, it could be as a physician at the office, it could be the nurse practitioner at the office, it could be, if they have another need, it could be the referral person. So really that closed loop is the most important thing, that patient gets their needs met and that the information is not only shared, but it's also documented in the EMR. So everybody has access to it.
Got it. Thank you both for clearing that up for our readers. We appreciate it. The next question is from an audience member who's asking, is there any information about the stability of the patient population for whom the interventions were so successful?
I'll take a stab at that. So I mentioned this earlier, but part of Care Signal's model is, let me see if I can get to the right slide here. Part of Care Signal's model is to conduct rigorous academic research on our programs prior to bringing them to our commercial partners. One example of that is with COPD, where with Esse and other partners, I'm pleased that we've really replicated or improved upon these results. But our initial randomized placebo-controlled trial, which even controlled for the Hawthorne effect, which is a noted problem in most digital health interventions, showed a more than 61% hospitalization risk reduction versus control for more than 160 patients over 6 months. The average income for this patient population hovered right around $10,000 per year. Health literacy was, of course, extremely low, and thus all of the questions were and remain written at a 4th to 5th grade reading level to make sure that everything was accessible as possible, and phone calls were used even if individuals were not literate. The stability of the patients here, we didn't have any other, cherry picking or inclusion criteria beyond having poorly controlled COPD. So, that best answer I can provide is we really try to make sure that this works for really anyone. No one can escape care signal.
Well, that's great to hear. Let me actually stick with you for this next question as well, Blake. Can you comment on your payers or insurance companies' responses? Have your payers partnered with you for certain patient populations?
Oh, great question. It's a privilege to have partnered with everyone from some of the Aetna joint ventures through to payers that serve state employee populations and blue-collar self-insured employers. And the short answer is it's very similar outcomes. In the case of payers, especially now, sometimes there's an even clearer line of sight to returns on investment, by driving down costs. The time horizon for those returns can be pretty short, even with longer-term conditions such as diabetes. I would say on the provider side, we bias slightly more towards COPD and CHF management, and on the payer side, it's a very slightly younger population on average, with more use around diabetes, hypertension, and then behavioral health conditions as well, everything from substance use to depression.
Got it. Thank you again, Blake. The next question here is, have any studies been done to measure the impact of the use of remote patient engagement technology on patient satisfaction scores?
That's a good question. We have, at least I can speak for CareSignal, and I'd be glad to follow up and share one of those, which is a New England Journal of Medicine Catalyst publication focusing on substance use, although we've replicated that in a number of condition-specific publications. I think anecdotes are almost as powerful as data here. Patients view the asynchronous communication as not only being easier than a phone call from a provider, but also being less judgmental, and they're more likely to provide honest and accurate answers at their own convenience. CareSignal tracks for all of our partner patient populations or member populations, not only their satisfaction with the technology itself, but also their perception of any improvement in the quality of relationship with the clinical team, which is consistently improved across all conditions. I guess it goes to the point that more engagement and more clinically relevant engagement lead to better relationships as well as outcomes.
Perfect. Well, it looks like we have time for about one more question. Some audience members have been asking, who is CareSignal's remote patient engagement platform designed for, and more specifically, has CareSignal worked with patients who have multiple chronic conditions such as end-stage renal disease? So maybe, Blake, you can shed some light on that before we unfortunately have to end the presentation.
Sure thing. Thank you, everyone, for the great questions as well. In fact, our very first peer-reviewed publication in one of the Nature Journal scientific reports was on dialysis and improving attendance while also reducing hospitalizations by more than 54%. And I've put on the screen this intimidating list of conditions, which are most, but not all of the conditions that CareSignal currently supports, broken down by category. When patients have multiple chronic conditions, that's really where CareSignal shines. We're able to effectively capture patient-reported outcomes from multiple conditions for a given individual, incidentally at no additional cost. But we also have shown in our research an all-cause hospitalization and morbidity reduction when just one program is used. So we have the flexibility to support multiple comorbidities, but really even one is way better than nothing.
Wonderful. Well, that is all the time that we have left for today. I want to thank Blake, Carla, Aaron, Dr. Schlanger, and Rob for such an excellent presentation, and thank you to CareSignal for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thanks, everybody.
Thank you so much.